On the topic, the reason I say 15 minutes and hopefully not more, because this is a very, very big topic. It was sort of difficult to get all the really important things that I'd like to say in. So broadly, I'm going to talk about emotions and their regulation. And reflecting the difficulty of the topic, I have many main points, but I'll summarize these main points into mainer points. And I think I'm going to focus on talking about mood variability or mood dysregulation as a chief complaint in medical care. And the two diagnostic entities which are best characterized by unstable mood or so-called mood swings would be bipolar disorder and borderline personality disorder. One is increasingly expanding in popularity, and the other has not grown, even though it probably should be reversed order. So I want to talk about some key differences between those two diagnoses, as well as the consequences to misdiagnosis, because missing borderline personality and treating it as if it is some form of bipolar disorder not only exposes the patient to the risk of serious harm from medicines with low likelihood of benefit, but it also is a missed opportunity because there are treatments that are actually really good for any number of difficulties of emotional regulation, and those are psychologically based rather than pharmacologically based. So theories of mood posit that we have these moods to let us to enable our survival. So moods are designed to be either motivating or painful. When we have pleasant moods, we're motivated to repeat the behaviors that lead to those moods because that may have to do something with food or sex, and that promotes the survival of the species. And when we have unpleasant moods, that is thought to be evolution's gift to us to avoid situations which are likely to cause us harm, including isolation from our clan, because as human beings we can't survive alone. So we're very, very attuned to social cues and to social standing and steps related to that. So moods are sort of hardwired to create intense pain or intense pleasure, and when they create intense pain, we seek out in these modern times doctors more than, say, priests or rabbis or close friends, because we have a really strong messaging in our culture that moods are medical conditions which have medical treatments available, and so why not go to see the doctor about that? A couple of really interesting things happened in the 1990s. One was the introduction of Prozac, and the other was the introduction of Depakote. Prozac made the treatment of depression something that any clinician with almost any level of training can manage. The SSRI medications have, compared to everything else that was in existence at the time, the SSRI medications were remarkably safe and reasonably effective. So it moved depression care, it moved the pharmacotherapy of depression care out of the psychiatrist specialist office and into any practitioner's office. And now that we have a number of additional drugs, the precedent that primary care doctors can take care of psychiatric issues is sort of well established and growing, so that primary care doctors are likely to see any number of mood complaints these days. Among those complaints are going to be bipolar disorder. Bipolar disorder is interesting in that we have well-established criteria for bipolar disorder that essentially hadn't changed from about 1970 until about 1996. And the prevalence of bipolar disorder was also remarkably similar across numerous studies from 1970 until about 1998. And the prevalence of bipolar disorder in what we'll call the older definition was remarkably steady. It was, say, around 1.5% of the population had bipolar disorder. And then a curious thing happened. On this, the slides are available, and you can request them and read all these details. But the point of this timeline is that we've recognized mania for more than 2,000 years, and it was a fairly established concept with a fairly constant rate of prevalence in the population. 1996 is bolded because that's when Depakote received FDA approval for marketing for the treatment of bipolar disorder. And then we have, in 1996, a paper comes out with the subtitle Beyond DSM-4, which introduced the idea that maybe we should look at bipolar disorder as a spectrum. And after that, we see sort of increasing prevalence estimates. So now bipolar, which was once a comparatively rare disease, is now said to comprise maybe 30% of all depressions, or 10% of all people in society. So we have markedly expanded the notion. Well, there have been efforts to expand the notion of what counts for bipolar disorder. And what happens with not only with drugs for bipolar disorder, but with any other new psychiatric medication, is that with every time the FDA approves a new drug, there are renewed efforts to educate clinicians about the disease state. These educational efforts usually go along with trying to expand the notion of the disease that you once thought you knew to include stuff that you maybe only wondered about. So they let you know it's out there a lot. And then they do direct-to-consumer advertising. So consumers come to us and say, "I have mood swings, and maybe it's bipolar disorder." So there's lots of efforts, and the reason that they keep repeating this playbook is because it's very effective at getting prescriptions written. And another thing that happened in the post-Depakote world is that the term mood stabilizer was actually almost never used. Occasional references to the concept of mood stabilizer were in the psychiatric literature, saying that the goal in the treatment of bipolar disorder was to reduce the probability of mood episodes. So drugs that could reduce depressive episodes or manic episodes would be the ideal thing. But mood stabilizer is now widely used out there in the popular as well as the medical lexicon. And it's interestingly a term without any standardized definition. It's a term that is unknown in official DHA in official FDA publications, and it's a really kind of clever or insidious term, depending upon your orientation, because it suggests that it can do many things. Among them, that it can stabilize mood in people who the mind goes have unstable mood. So I think it's widely popular by somebody's design, but I think it's unhelpful because meanwhile, while we're expanding the concept of bipolar spectrum or the notion of so-called bipolarity, we've seen no movement on this entity called borderline personality. Nobody has tried to expand the concept of a borderline spectrum or subsyndromal borderline personality disorders and so forth. And remarkably, go again, bipolar disorder by the old definition was about 1.5% of the population, and by a conservative estimate, 6% of the population are affected by borderline personality disorder. And if we were to expand the definition or say, borderline-ality, you may see significantly higher prevalence of people with the borderline features. For later review, here's a list of the criteria for borderline personality disorder, but I want to highlight the key thing. In my view, the thing that defines the borderline patient is a highly reactive mood. It reacts very easily to maybe relatively trivial environmental or social stimuli or thought stimuli, and once reacted, the mood is a high amplitude excursion from normal. So what you or I might consider to be frustrating to somebody that has an overreactive mood may be devastating. If a relationship or a social engagement I had planned doesn't pan out, I might call that disappointed. Whereas if I had an overly reactive mood, I might say this is abandonment. So when your moods are sort of out of your control and run to the extremes, they really hijack reason. So in an extreme state of panic or despair, it becomes very difficult to tap into alternative points of view because they just don't feel as true as the severity of the insult. So if I had a social engagement with somebody and that is canceled, and I am my emotions are flooding me with feelings of panic and fear and abandonment and rage, it's very difficult for me to believe that maybe the person still likes me and they really just had something else that they didn't want to avoid. It just doesn't feel consistent with what my emotions are telling me. So I say something, that we're subject as human beings to a thing I call the feel makes it real. So when we have high emotions, the ideas that go with those emotions are we deem them with truth, even though logically there may be no reason to do so. So I think the fundamental thing that goes on is that there is a disease state characterized by highly reactive moods and high amplitude excursions of moods. And when that happens, everything else of the borderline syndrome falls into place and can be easily explained. So if I'm terrified of abandonment, then of course I'm going to do things in relationships to maintain them that are not healthy for those relationships. Of course I'm going to experiment with drugs or food binging or reckless driving or something to distract my emotions. And if I ever do self-injurious behavior like cutting myself, I find that doing that really focuses me on one act, and then I cannot pay attention to all these other distressing thoughts. And all of these, what you call coping skills, are effective. They're actually far more effective than almost anything else. So in the short term, they get repeated, and there you have that central feature of mood reactivity can easily explain everything else. So, but in clinical, again, we're not as a society, on television advertisements, on journal articles, in the things that you get for free, nobody's really talking all about the borderline patient because there are no drugs for borderline patients. Rather, they're talking about the various forms of bipolar disorder. So bipolar is top of mind, and part of the reason I decided to have this discussion is because in all treatment settings, whether primary care or psychiatric, the patients with personality disorders are substantially overrepresented and rarely recognized. Estimates about in studies of the treatment-resistant mood disorder population, some estimates say that personality disorders are present in 80% of treatment-resistant patients. So recognizing a personality disorder or recognizing what constitutes a so-called personality feature from a so-called Axis 1 feature, it will be really, really helpful in helping that group of treatment-resistant individuals to have better outcomes. So for reference, bipolar disorder is typically one mood episode every several years. Rapid cycling, when it was realized, was thought to maybe occur like 4 times per year. So that's the historical notion of what the frequency of mood episode is in real bipolar disorder. And mood disturbances are episodic. They last for 7 or more days, usually many weeks or months. And then they resolve. And then there are usually periods of euthymia or dysthymia, but there are discrete episodes in which the predominant mood state is always there. Borderline patients or mood reactive patients have many mood episodes per day or many mood episodes per week. Moods, if disturbed and manic, it's constantly manic. If in a mood disturbance in borderline, it's elevated 1 minute and crushing sadness the next, and so forth. Most people with bipolar disorder, if you ask them, do you have a sense of who the real you is? Yeah, I know what I am. But if you ask that to a typical borderline personality disorder patient, they will usually say, I have no idea the real me. So it speaks to the identity disturbance. And indeed, how can you form an identity when your whole life is just from pillar to post because you're following these emotion reactions? So important distinction between these two, because for classic bipolar disorder, almost anything that has FDA approval will work extremely well. For borderline personality disorder, not so much. And people have tried, and God bless them for doing so, to meta-analyze the literature on pharmacotherapy for borderline personality disorder. And if you look at different meta-analyses, you see very little agreement. That's because some medicines do work. But they work for a minority, and what, if lithium worked for Joe, lithium's not going to work for the next 7 patients that you find, but lithium will be the thing for Joe. So pharmacotherapy and borderline personality is worthwhile to explore, because some agents do work for some people. It's just they don't work reliably enough to make generalizations. And the great risk, though, in focusing on pharmacotherapy is that in a culture in which everything is seen as bipolar, and which everything is seen to have a medication solution, when you and your patient are trying this medicine and that medicine and talking so much about medicine, it's sending an unhelpful message that you have a chemical imbalance, quote unquote, and that with enough time and patience, you'll find the right medicine. And this is a shame, because we have actually good psychotherapies that are more reliably helpful and get more at the root of the problem. I'm going to try to speed up because I don't want to go over my time budget, but I just want to make a somewhat snarky comment about degrading to my field, because I think it was a really great injustice to humanity to call it personality disorder, because honestly, nobody knew, and nobody knows what the real etiology of these disorders are. So to say it's personality disorder implies a certainty, which is completely unjustified. And this graph shows you the consequence of labeling. This shows you the number of studies in PubMed that address pathophysiology, or biochemical distortions responsible for schizophrenia, depression, bipolar, or borderline. Look how much attention that serious biochemical scientists have given to the borderline personality disorder. That's because they called it a personality disorder. So I personally am convinced that this is fundamentally a biological distortion, but because of this 40 years of bad labeling, we're still struggling. On the other hand, when you label personality disorder, our colleagues in psychological science perk up, and they did rise to the challenge and came up with some extremely good treatments for emotion regulation. So we have great treatments, and that's why this distinction of emotion reactivity or emotion dysregulation, and separating that clearly from a bipolar disorder, is fundamentally important. The best of the psychological treatments, well, no, let me say of the psychological treatments that exist for mood reactivity, the one with the highest degree of evidence base is called dialectical behavior therapy. It's a weekly. It's like going to college. It meets weekly. There's a group class, and there's an individual coaching and therapy component. It focuses on 4 key domains: mindfulness, distress tolerance, practicing interpersonal affective skills, and emotion regulation skills. None of it is highly complicated. It's just a matter of learning it and applying it. If I tell patients that I think you have borderline personality disorder, most of them have already suspected that might be the case, but have been resisting that because that's a really bad diagnosis, quote unquote. And I actually tell them, I think if I had to have a major mental illness, I would choose borderline personality, because we have effective psychological treatments that can get at the root of the problem, that don't expose you to a whole bunch of nasty drug side effects, and people routinely recover from this disease and have long-term recoveries with the pharmacotherapy. So we have good treatments that don't involve pharmaceuticals that can produce long-lasting fundamental change. So it's actually a good prognosis illness, but it requires a couple of things, like you just have to practice this. So I tell them that doing DBT skills is a lot like learning a new instrument or learning a new language. The good news is everybody can do it if they just do some practice. The bad news is that practicing 5 minutes of breathing, or practicing some distress tolerance or other skill, is going to give you like a tiny relief in the moment. And that's going to pale in comparison to what a shot of whiskey or a dose of Xanax used to do for me. But the good news is, with continued practice, you get better and better at it, and then the effect size is actually better. So the treatment is highly effective. It just takes some time, and having this discussion about equating it to learning how to become a good weightlifter, or a marathon runner, or a Spanish speaker, or a guitar player helps to keep it within the realm of possibility. And it requires the clinician to constantly reiterate that message and notice the improvement that people are are making, so that there can be, more, there can be better short-term recognition that this is working. And so to summarize, mood variations are normal, and mood variations can be painful, so they're their most frequent cause of psychiatric consultation. Not everybody with severe mood disturbance is going to have a major diagnosis. It can be a standalone problem, and the good news is that learning emotion regulation skills can be used for a whole bunch of people, even without a disorder per se. And when we diagnose somebody with bipolar or borderline, that has a whole lot of additional freight attached to it, so we should be very cautious in assigning any of those diagnoses, but still acknowledge that emotion regulation or emotion dysregulation is painful, is worthy of attention, and that there are good treatments that can address that. So that's that. Thank you very much.